The aim of this video today is to demonstrate the correct techniques for retinal examination of a small animal patient and to demonstrate what instruments are available for retinal examination. It's important to remember that examinations should be undertaken in a dark room with only residual background light for safety reasons. In order to achieve a thorough and complete retinal examination, mydriasis is an important step to prevent missing lesions and getting an inaccurate or incomplete diagnosis. Mydriasis is best achieved with tropicamide, a short-acting agent, rather than atropine, which may last for several days in a normal dog. There are three forms of ophthalmoscopy: close direct, distant direct, and indirect. Distant direct is dramatically underused and will give you a lot of information about opacities within the visual axis. This technique requires that from arm's length away, the observer looks through the ophthalmoscope on a setting of 0 diopters for a normally sighted person and uses the tapetal light reflection to assess whether there are any black opacities present within the visual axis. These may be located anywhere from the precorneal tear film through to the retina. Once a black opacity has been discovered, it is important to assess if it moves within the visual axis. When the examiner moves from left to right or up and down, if the opacity remains static, then it's within the plane of the pupil. However, if the opacity moves in the opposite direction to the examiner, then it's in front of the plane of the pupil, and if it moves in the same direction as the examiner, then it's located behind the plane of the pupil. This technique can be used to help differentiate nuclear sclerosis from cataract, as nuclear sclerosis will still have a clear tapetal light reflection, despite the obvious grey appearing lens on focal illumination, whilst cataract will appear to block some of the tapetal light reflection, resulting in a black opacity. Retinal examination can be done in several different ways. Probably the most useful and underused in practice is indirect ophthalmoscopy. For this you need a hand lens and a focal light source. It's important to make sure that the hand lens is used the correct way around, with the silver rim facing towards the patient. The focal light source is held up close to the examiner's eye, either to one side or underneath it, and the hand lens is held at approximately arm's length away between the thumb and the forefinger, and approximately 5 to 10 centimetres away from the cornea and parallel with the surface. I'd recommend that, like a snooker bridge, the little finger is rested on the patient's head as far away from the lid margins as possible to help with stabilising the hand lens. With this technique, the examiner can observe through a dilated pupil approximately half of the tapetal fundus, and with minimal movement, a picture of the entire retina can be quickly obtained. Once this technique has been used for scanning the retina, close direct ophthalmoscopy can be used to have a closer inspection of any lesions discovered, and also for a close look at the optic nerve head and retinal vasculature. Indirect ophthalmoscopy can also be achieved with the aid of a head-worn binocular indirect ophthalmoscope. This has the added advantage of providing a free hand to stabilise the patient, and as the light source is mounted within the optics, prevents it from being out of visual alignment and decreasing the visual illumination. In order to set up the indirect ophthalmoscope, adjust the headband so that the instrument is supported comfortably around the top of the head. It's then necessary to set up the ophthalmoscope angle alignment. To alter the vertical angle of the ophthalmoscope head, use the adjustment knob on the side to bring it into alignment with your glasses or your eyes. Place an object, perhaps the thumb, approximately 40 centimetres from the face and centre it horizontally in the light patch. Then close one eye. Using the thumb and forefinger of the opposite hand, slide the optic of the open eye, located directly under each eyepiece, so the object moves into the centre of the field of view. Keeping the object in the centre of the light patch, repeat for the other eye. The light beam may then be selected depending on the pupil size and experience of the examiner. On many of the head-worn binocular indirect ophthalmoscopes, a diffuser is present. This unique extra-wide beam of diffuse light permits a more relaxed technique during more challenging fundic examinations. Beginners may also find this aperture particularly helpful, since the alignment between the headset, the condensing lens, and the pupil in order to achieve a full lens image is not as critical as with the conventional beam. There is a simpler version of the head-worn indirect ophthalmoscope, which is worn on glasses and has a separate back-worn battery pack. There is less selection available on the light sources, but this simplification is reflected in the price. Close direct ophthalmoscopy requires that the examiner is no more than a couple of centimetres away from the cornea of the patient he is trying to examine. And for this reason, it's recommended that the examiner learns to use his right eye for the patient's right eye and his left eye for the patient's left eye. It's important to check the voltage of the handle and ophthalmoscope head, as they come with two different voltages, a 2.8 volt, which is blue, and a 3.5 volt, which is red. These voltages are not mutually compatible. The ophthalmoscope should be set up to the user's prescription. For a normally sighted person, this would put the diopter setting on 0 for retinal examination. The ophthalmoscope is then used as demonstrated in the video. In order to change the diopter setting, if the dial is rotated anti-clockwise, then more negative diopters are selected, and if it is rotated clockwise, then more positive diopters are selected. On the direct ophthalmoscope, there are several different light beams available, 3 different widths of light beam depending on pupil size, a slit beam and a graticule beam. Most ophthalmoscopes will also have a red-free filter, green light, for vascular examination and cobalt blue filter for fluorescein examination. The direct ophthalmoscope can be used to examine other structures within the eye rather than just the retina. This may be achieved by changing the diopter power to +8 diopters for the posterior lens capsule, approximately +12 diopters for the anterior lens capsule, and approximately 15 to 20 diopters for the cornea. The final technique for retinal examination is to use a monocular indirect ophthalmoscope, such as the Keeler wide angle. With the wide angle ophthalmoscope, it's important to set the instrument up prior to usage. There is a focusing diopter dial, and in order to set this, look through the ophthalmoscope at a distant object and move the slider up and down to get the image in focus. There is a magnification dial for low resolution and high resolution, and on the handle there is a rheostat for light intensity. The eyepiece tube should be extended for non-spectacle wearers. This instrument combines the advantages of a direct ophthalmoscope with those of the indirect ophthalmoscope, leaving the image seen as real, direct and large. For comparison with the other two ophthalmoscopy techniques, the wide angle will give a visual field of approximately 25 degrees, as opposed to 9 degrees with the direct ophthalmoscope, 56 degrees with the 20 diopter hand lens. Therefore, the visual field is about half that of the 20 diopter hand lens, but about 3 times that of the direct ophthalmoscope. The image is also the correct way up instead of inverted, and not back to front as with the indirect ophthalmoscope. All 3 ophthalmoscopes have their specific advantages, and only personal experience will truly determine which technique suits the practitioner best. However, there is no one technique that will cover all situations, and it's therefore best to gain experience in all equipment.